Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is Canavan Disease. Now, to help us understand this in a little bit more detail, we have with us today who's joined us Dr. Praveen Kumar, who's a senior consultant pediatric neurology at Sir Gangaram Hospital, Delhi. He's also the secretary association from the Association of Pediatric Neurology in Delhi. So, welcome to Medical Dialogue, sir. It's really a privilege to be having you on board here with us today.
Good morning. Thanks to I appreciate the whole initiative.
Great. Now, sir, we're talking about rare diseases, and our topic for today, as it's mentioned, that it's Canavan disease. So, if you can just tell our viewers, why is this considered a rare disease? Why is this categorized as a rare disease? What are the early signs and symptoms that one has to look out for? And what are the typical diagnoses? Is there any diagnostic test or aids that can help in its early diagnosis?
Fine. So, Canavan disorder or Canavan disease is really rare, especially in our kind of population. If you look at the world around, you'll find that it is slightly much more prevalent. The incidence is much higher in the Jewish population. So there it is almost in the terms of around 1 in 6,000 to 1 in 13,000 population. While in our part of the world, or the kind of like non-Jewish population, the incidence is almost 1 in 1 lakh. So definitely it is uncommon. We don't have data from the India, but overall what we see in our clinical practice is also two things, that we suspect it a lot because of knowing it from many years on the part, and the incidence is not known from the our country, but definitely it is there on the part. So as you mentioned that Canavan disorders is a neuroregressive disorder. What we understand this as a leukodystrophy. So leukodystrophy means that there is a dystrophy of white matter. So this is a white matter disorder predominantly. Ultimately it affects the grey matter also, and which is genetic. So this is a genetic condition which causes disturbances or disorder of white matter of the brain in that sense. This is also called a spongiform leukodystrophy. I'll tell you why this is called a spongiform leukodystrophy. So as a clinician or as a practitioner, when do you start suspecting Canavan disorder or Canavan disease in that case? So normally these disorders present in two classical forms, the typical and the atypical one. So typical one, that depends upon the age and the severity of the manifestations. So the typical one starts early in the life, in the first 6 months of the life, while the atypical are latter part of the year, maybe around 2, 3 or 4 years, or maybe later than 5 years of the age also. They also are labeled as juvenile Canavan disease on the part. So the cardinal feature of Canavan's disorder is macrocephaly. If you want to remember one thing about Canavan, this is macrocephaly. Apart from that, they have head lag, and they will have developmental delay on the part. So these three are very important features of Canavan disorder: macrocephaly, head lag, and developmental delay. So typically you find a child who was born maybe almost normal at birth, he was well for a couple of months, and then the parents feel that now he's not developing so well, and then he starts losing his milestones by the time he is brought to you. And when you see a child, what you see normally is a child has got macrocephaly, he is unable to hold his head on the part, he has got diffuse, to start with hypotonia, the muscle tones are less, and subsequently when you examine them closely, you'll find that they are not fixing and following. Eye contact is not good. He might show you signs of nystagmus also on the part. Gradually, they may have some swallowing and sucking difficulty also because of the involvement of the bulbar tracts in the part. Definitely, hypotonia will be predominantly there on these patients. And later on, when you follow these cases, you find that the hypotonia has converted into, or it now gives way to the hypertonia and spasticity, which is a manifestation of white matter tract involvement of the part. Along with that, hearing impairment is not a very common feature of these disorders, but sometimes children can have hearing impairment also. And along with this, many people also have reported cases of microcephaly along with or normal head circumference also along with the macrocephaly part. So this is the classical picture of Canavan's disorder. A child who is neurologically regressive is developing delay along with the regression part, and you are having all those features of white matter tract involvement on the part. Regarding coming to the second part, when you start suspecting, there's a whole lot of differentials for a child who comes with the developmental delay and these kinds of features. But as I mentioned to you, that the classical feature is about macrocephaly, which gives you kind of like which narrows the differentials to quite a few number of cases, which comes to you with the macrocephaly in the early part of their infancy. There are not many disorders with macrocephaly in those ones. What normally we do, that when we suspect this disorder, we ask for certain investigations which are there in the blood, in the urine, and in the as a neuroimaging part. So I'll start from the blood. So like in the Canavan disorders, we send the blood samples and we send for the metabolic screens, which may show increased amount of N-acetylaspartic. I'll tell you why it increases. Similarly, when we send the urine sample, you may see increased amount of N-acetylaspartic, that is NNA. And when you do the MRI brain, this is very, very important thing. When you do the MRI brain in these kids, and normally you do because they have come to you with the macrocephaly and developmental delay and now regression on the part. But you find that MRI may show abnormalities in the white matter tract. And but most importantly, you need to ask for MRS also, magnetic resonance spectroscopy also, MRS part, along with these kids who come to you with the macrocephaly and developmental delay, because MRS may tell you the same thing which you are seeing in the urine and in the blood, and at times MRS may tell you the thing which are not there in the urine, the same like increased amount of N-acetylaspartic, increased NNA. So you write specifically when you send this patient for the MRS that you look for, or you tell me about the amount of NNA in the brain on the part. So what happens that in Canavan disorders, there is an deficiency of the enzyme, what we call them ASPA, ASPA on the part. This is an enzyme which is normally responsible for the degradation of N-acetylaspartic. So because of the genetic deficiencies, the enzyme is lacking, the ASPA enzyme is lacking, and that is why the N-acetylaspartic, which is an amino acid, which is not hydrolyzed, it's not broken down on the part. And because it is not broken down, so it starts accumulating in the cells, especially in the oligodendrocytes, which are responsible for formation of the myelin part. So gradually what happens that the oligodendrocytes, they start breaking down after becoming swollen on the part, and you lose your white matter function in the brain, which reveals itself by the symptoms of developmental delay, later on hypertonia, spasticity, especially your vision loss also. It also manifests with the clinical seizures in the part. And when you do the MRI brain, you also find the white matter tract involvement, including the U fibers on the MRI brain. And you see increased amount of N-acetylaspartic in the MRS part. This is in brief about the Canavan disease as a clinician.
Great. That's actually a quite expressive way of actually describing what signs and symptoms one has to look out for and what diagnosis one can go ahead with it. Now, sir, what are the current standard of care for managing Canavan disease, and are there any emerging treatments? Is there any developments in those lines?
So there are two things. The brief answer is we don't have a real kind of like out of the counter medications to treat the Canavan disease. That's the number one thing. The second thing is this, definitely a lot of research is going on. People have been trying since more than 2 or 3 decades for finding a gene therapy for this Canavan disease to replace or to help the gene which is deficient, the ASPA gene which is deficient on the part, by utilizing different vectors, the viral vectors which is being used, especially the other cases also like in the SMA and those ones what we are finding. So gene therapy is being tried. They have been tried with the different population also with the modest success, but has not come in the real clinical world. People also have tried the the induced pluripotent stem cell therapy with some modest success, and people are also trying to use the molecule like lithium citrate and those ones which can reduce the amount of toxic metabolite, the NNA in the brain on the part. So a lot of things are basically being worked upon, People they are being in the research also, and they are being used in the patients also, and maybe in couple of years we'll find more thing which is more readily available. That's the one thing. Second thing, because there's no definite treatment, we need to have a kind of like multi-specialty management of these kids. So as this is a leukodystrophy, as this is a neurodegenerative conditions, so these children typically have a significant developmental delay. So they require a very good nursing care. They require a very good occupational therapy, physical therapy care to make them more mobile in the joints. They require feeding help because they will have a sucking, swallowing issues on that part. They will need to have a kind of like visual aids also because they lose their vision in that context in a way. And along with that, they suffer from most of them suffer from the refractory seizures also. So they get a lot of convulsions, seizures, epilepsies. They also require anti-epileptic or anti-seizure medications. This has to be a kind of like multidisciplinary management along with the physician, neurologist, the therapist, taking care of these kids to prolong their life and to make them much more amenable to therapies maybe coming on.
So basically, if I just make concise, it is basically symptomatic treatment. So whatever symptoms the patient shows, if there is vision loss or any developmental delay, so treatment management, like seizures you mentioned, so anti-epileptic medication can be prescribed. So it's basically symptomatic medication and treatment care that can be given to such patients, right?
Yeah, true. So this is symptomatic management, and because once you know the disorder in advance, the disease in advance, you always know that what is going to happen to this child. So sometimes because you already have diagnosed the patient with Canavan disorder, Canavan disease, he might be having the vision problems. You'll be looking for the vision problems frequently, even if the parents are not saying about the signs. You're looking for the subtle signs of the seizures in those cases. You're anticipating the problem and you're guiding them beforehand about the possible interventions. So that's the basic motive also on the part.
Great. Now, sir, if I may ask, how does this disease progress over time, and what can be the typical life expectancy for individuals who are with this condition?
So, by definition, this is a neuroregressive condition. So, with the time, they will go down only despite all our measures on the part. Initially, they may have slight developmental delay, but later on, this is the kind of like they will tend to have a regression only. So, as I mentioned to you in the beginning, there are two classified forms: the typical and the atypical one. The typical one, which starts early in the life, in the first 6 months. These children, they have a kind of like have an early mortality by around 2.5, 3 or 4 years of the age, maybe on the part because of the ongoing neurodegeneration, which takes jeopardizes their ability to live, especially with the pulmonary sucking, swallowing, all those kinds of like abilities going off with the part. The second part is that the children who are slightly of the older age, manifesting with the Canavan, the juvenile ones, they may live for a longer duration. So because they have got modest signs and modest symptoms, so they may live for a slightly longer period, and they have got different needs to be fulfilled or answered, like visual impairment, again their gait, again their swallowing issues, but not to the same level as the child with a typical Canavans who doesn't live beyond maybe the initial couple of years.
Oh, okay, understood. Now, sir, are there any recent developments in gene therapy? Now, you were talking about emerging treatment care, and obviously there is research which is going in a couple of years. There might be more management protocols that have been laid out. So, any recent advancements in gene therapy or any other research that can offer a cure for this disease?
So people are trying. As I mentioned to you, that they have tried with the different viral vectors on the parts. Like they tried with the viral vectors, getting implanted into the brain and then taking care of the deficient enzyme. So when they injected into the gene, the normal human gene carried by the viral vector into the brain, so they found that it was not so much responsive on the part. So then they change their, I'm trying to make it simpler on the part. So then they change their methodology and they try to inject the viral vector with a normal gene into the white matter, because that is that is where the disease lies the most on the part. So then they found to be much more helpful in enhancing the life of or enhancing the functions of the white matter on the part. So these are definitely on the horizon in those cases where they are using different viral vectors to enhance the deficient enzyme, the ASPA one in a way. And as I mentioned to you, that they're also looking for those the stem cell therapy, especially with the pluripotent one, because that is slightly much easily available and the cheaper on that part. And there have been cases also who have been tried. It's not only in the kind of like in the animals or in the research lab. Children have been tried with these gene therapies with modest success.
Okay, great. Now, sir, are there any specific neurological symptoms or complications for such patients that is actually particularly very challenging to manage for such Canavan disease patients?
So, like, if you look from top to bottom, so what they have is basically neurodegradations, like in the head, na? So macrocephaly with neurodegradation. So, although it starts from the white matter, it involves the gray matter also. It means that they will have the locomotion, motoric, gait problem, but subsequently they have their cognition, they have their higher mental function also getting involved in the subsequent months on the part. So, it means that interacting with them becomes a challenging part, because once someone interacts with you, you can command them to do some kind of activities, physical activities on the part. So interaction with them, because they lose their interaction, the cognition part, that becomes one challenging in a part. The second thing about the seizures, as I mentioned to you, that also becomes at times difficult to treat. Most of them, they are manageable with the medications. The third is the vision loss. They start with the nystagmus, but subsequently they had this non-ocular vision loss because of the cortical atrophy on the part. Hearing loss is not so frequent in these cases, but people have given their cases with the hearing loss also, seen hearing loss also. Sucking and swallowing, the feeding becomes a much more challenging these cases, so they require assisted feeding, tube feeding, or maybe the pig feeding on the part. Joint contractures. A lot of times they get dislocated. Joint gets dislocated because of the severe contraction, severe joint immobility on the part. That becomes much more difficult to manage because and difficult to handle the child also in those cases. So top to bottom, they have these kinds of like multi-organ care assistance required on the part.
Okay, so now, sir, coming to the next part, you were talking about multidisciplinary care. You mentioned that there is a team which is required to actually manage for such patients. So, if I may ask, what role do neurologists play in the care of such patients? Is there any particular thing that you would want to highlight on?
So, the first thing is definitely diagnosis, because most of these kids are brought to us referred by their primary pediatrician, because once they go to them for their regular vaccination, maybe say around 3 months of the age and 8 months of the age, 12 months of the age, when their child for the normal routine primary immunization taking place, and the pediatrician, which is quite astute clinician, he recognizes the child is not having his, he's not holding his head, he's not interacting as much, he's hypertonic, and his head circumference appears to be on the larger side. So he refers to us on these cases. A number of times parents also bring the children directly to us on the part. So and then we analyze them clinically. We find them that this child is definitely lagging in the development. He might be regressing also. And as we are repeating our clinical signs, so that it becomes much more easily known that a child who comes to with the macrocephaly, nystagmus, hypotonia, head lag, you suspect Canavans, especially if it is less than 6 months of the age. So we diagnose these cases, and then we send the relevant blood, urine, and the MRI. We make sure that we do the MRS also, for the same reason we discussed before, to look for the NNA in the MRS part. That's the first thing. Second thing, once you diagnose these conditions, so we start their relevant need-based therapy. So like definitely they start with the physio and occupational therapy. They will be guided for the nutrition part in that sense. They will be guided for the, if they're having seizures, they'll be guided for the first aid measures for the seizures part in a way, and we try to give them about their prognosis part also, and maybe what is available about the therapies in those cases. The third thing also becomes, we also guide them about the possible recurrence in the further pregnancies in their family. So definitely we ask them to meet our genetics team also to get it confirmed by the further gene evaluation for the deficient enzyme gene, and to get them counsel about the prevention of further recurrence in the family. And this is an ongoing process, so they have to be seeing us in the follow-up part to look for the newer signs and symptoms, because that's the neurodegenerative conditions. You may be finding newer signs and symptoms, and definitely to be addressed to, and to addressing their newer complications also. Whenever you see a child who is less than 6 months of the age and who has come to you with developmental delay, when you examine, you find the child has got large head size, he can't hold his head, it means he has got head lag, and he is having hypotonia. If you do the reflexes, it will be on the higher side. You suspect Canavan's disorder in these cases, and there are 3 simple tests. The first is the blood, which you send for the tendon mass spectroscopy. The second is the urine, which you send for GCMS, gas chromatography mass spectroscopy, for increased NNA. And the third, final, which is more important, is that you do the MRI brain, but make sure that you also ask for the MRS, because a lot of children require MRI with the sedation, and when you have to do the MRS again, you require sedation again. So when you send them for the MRI brain, you also include MRS, that will be clinching the diagnosis even before you have the urine and blood in your hand. Thank you very much. Thanks.
Thank you very much, sir. Thank you for all your insights.
Thank you. Thanks a lot. Thanks for having me here.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.